monthly academic webinar organized by Department of PMR SVNIRTAR under the aegis of IAPMR and Odisha chapter of IAPMR. Friends, neurogenic dysphagia is one of the frequent life-threatening symptom in acute neurological conditions such as high cervical injury, traumatic brain injury, or hemorrhagic stroke. There is always a risk of aspiration pneumonia and thereby increasing mortality because of significant higher chances for infection and aspiration pneumonia. So there are different methods of assessment of dysphagia or swallowing disorders. Out of that, this fiber optic endoscopic evaluation of swallowing is most commonly used and frequently used tool for objective assessment of dysphagia. Where this facility is not available, very often we use this video fluoroscopic method, but this fiber optic endoscopic assessment is a most reliable one and give a accurate objective assessment on vision about the vocal cord movements and the swallowing pattern. So today's speaker is Dr. Gourav Sannyasi. He is consultant in Manipal Hospital, Kolkata. He has completed his post-graduation from CMC Vellore and he has done his postdoctoral fellowship from Nimhans. Currently, he is working in Manipal Hospital, Kolkata. He has also working experience at in Institute of Neuroscience, Kolkata. So, without wasting time, I invite Dr. Gourav Sannyasi to speak on this fiber endoscopic evaluation of swallowing. Over to Dr. Gourav.
Yeah, thank you so much for the introduction, sir. And thank you, everyone, my seniors, professors, my colleagues, and my juniors present in this webinar. Am I audible now?
Yes, yes, you are very much audible.
Yeah. Okay. So fees is it's not I think most of the hospitals it's people are doing fees to assess dysphagia and to sometimes to assess whether the tracheostomy to be taken out or whether IS tube to be removed, whether you allow the patients orally. So I'll just go about the brief about the swallowing and the fees, what we see in the structure. In our hospital, we have been doing this at a regular basis. Stop. Yeah. So introduction is like we see almost in 50% of stroke patients, dysphagia is a very common problem, and it is, I would say, it is not only underdiagnosed, it is always a hidden problem because most of the time there is silent aspiration, which is very difficult to pick up in your clinical examination. Silent means when the patient doesn't have any cough, no symptoms of aspiration when you see from outside. And we know that most common complication of a stroke patient is aspiration pneumonia. That's because of this dysphagia and aspiration. So bedside clinical examination is, I would say, it is insufficient, but we should do at any patients at the day one of admission in a stroke ward. And if we have the fees, then it is very reliable. It can be done bedside. The most important advantage, we can real-time visualization of the whole swallowing process, mostly the pharyngeal and the laryngeal process. And it can detect silent aspirations. And based on the fees findings, we can guide the therapy also. So it has both diagnostic and the therapeutic advantage. Now, what is fees? It is a fiber optic endoscopic evaluation of swallowing. It's a bedside endoscopic procedure used to assess the pharyngeal phase of swallowing by directly visualizing the larynx and pharynx during the swallowing. So I'll just see the other video, we can play it. No. Yeah. So I'll just play this video. So the scope is introduced. We can see the turbinates. I'll go a little bit slow. So you can see this is the septum and this is the inferior turbinate. So this is, can you see my cursor?
Yes, yes.
I'll put a laser. So we are going from the right nostril. So this on the medial aspect, this is the septum, this is the inferior turbinate, this is the floor of the nasal cavity. So the scope is introduced. It's negotiated through the nasal cavity. Here, uh, this is the level of the choana or the posterior end of the nasal cavity. Now you can see something is pulsating here. This is the soft palate. You look at the floor. This is the soft palate, and this is the posterior wall. That is the level of adenoid. And this opening is the esophageal tube. So now it is in. So this is esophageal opening, soft palate. So you have to go through this. So now we have to negotiate the scope a little bit downwards to enter the nasopharynx. Now going down, this is the posterior wall. And the down, you can see the base of the tongue. So this is the base of the tongue, this is vallicula, and this is the epiglottis. Yeah, so in this level, what you can see, this is the epiglottis, this is the arytenoid. This aspect is the arytenoid and epiglottis, so it will be epiglottic fold. Just medial to that, there will be a false vocal cord, and then next to that is a true vocal cord. And this structure just where the both arytenoid is meeting, just behind that, there will be esophageal opening. And just lateral to that, this area is the piriform fossa. And what you are saying, this is the posterior wall of the esophagus. So sometimes a lot of patients we do who is on Ryle's tube. So we can see the Ryle's tube here going through the posterior wall, entering the esophageal sphincter. I'll just play the complete one. Yeah, so this is the pharyngeal wall. So you can see the whole pharyngeus muscle is contracting. The arytenoid falls through. So far, so this is the normal anatomy of the anatomical structure, what you can see over fees. So I'll go to this already explained in the previous video. This is just a screenshot. So just remember the downward part is the anterior. So where the epiglottis is, and the posterior with the esophagus. So upper part of the picture, here it is the posterior wall. So while entering the scope, you have to make sure which one is the anterior and which one is the posterior. So that's you should make sure before taking the scope inside the nasal cavity. Otherwise, the whole picture will come upside down. Cannot. So this is the like what are the phases of swallowing? This is I'll go very fast. All us know first is the oral phase or oral preparatory phase. Here the food enters the mouth. Here mainly oromotor muscles are required, starting from the lips, the tongue, and the velum or the soft palate. So if the soft palate is not closing against the posterior pharyngeal wall, there is a chance of aspiration. And then oral transport phase, where the food particle goes from the oral cavity to the oropharynx. And next, the pharyngeal phase. This is a involuntary control, pharyngeal phase of swallowing. It's triggered by the palatoglossalar arch. So palatoglossalar is the anterior pillar of the tonsillar bed, and the duration usually 0.5 to 1.5 1.5 seconds. Yeah, what happens? I'll just play on video. You can see here the esophagus is in the downward this wall. So this is the posterior, this is the anterior. Now the food, I'll just keep some food. So the yellow food, the puree food is coming. You could see, so nicely the food, there is no stasis, food is not accumulated, it directly went into the esophagus. So in between, just follow the video here. Yeah, so you could not see anything in between, no, just for 5 to 10 seconds. So what is happening? All the pharyngeal muscles is squeezed. So this is called whiteout phase. At that phase, your entire the larynx, the aryepiglottic fold and epiglottis closed. They squeeze with each other and obliterating the view. That's very normal and that is very common. And this is not an abnormal. This is called whiteout phase of of the swallowing. So at that phase, you cannot see what is happening. But this time, the vocal cord is closed against your scope. So this is the main thing where we like to see. This is the pharyngeal phase of the swallowing or through the feeds. And whiteout phase I explained already. Now the next phase is the esophageal phase, where the food particle will enter the esophagus through the cricopharyngeus muscle. So a lot of time what happens, so for this patient, whenever patient is swallowing, you could see that the food particle is coming into the puree to liquid food that is coming posterior wall, and there is no aspiration or no penetration. Or the food particle, I just added some color. So just proper visualization of the food, yellow color that is. I could not see anything in the vocal cord or in the inside the vestibule, laryngeal vestibule. But here you could see, just just notice here, yeah, little bit of food is coming in the vestibule, but there is nothing is going inside the vocal cord. So this patient is at risk of aspiration, but you can say he is nicely managing his food, whatever we gave during the time. So next is the central control of swallowing. Starting from the cortical, subcortical, and brainstem structure, all are involved. That's why in the cortical, starting from the somatosensory cortex, supplementary motor area, insula, cingulate cortex, even the basal, and subcortical structure like thalamus, basal ganglia, cerebellum. That's why whenever the patient comes with a stroke, even in the basal ganglia, we see there is a mostly problem in the oral phase, or oromotor phase, the weakness. But the main area, like a pontine stroke, mainly the brainstem, that is a key area, pontomedullary swallowing center. And when there is a brainstem issue, we have to be a little more careful with the swallowing there, because there will be a problem with all the lower cranial nerves. So there is a problem on the tongue, so oral phase, even the pharyngeal phase, because the vagus is there. So oral phase, pharyngeal phase, all will be obliterated because of the brainstem stroke. And cranial nerves, we all know which nerves are involved in, starting from the fifth cranial nerve to 12th. This is just a topographical correlation. Like it's a rough estimation. Like if the patient has parietal or like cortical structure, then there will be problem in that delayed swallowing. So as such, there is a no problem in the pharyngeal phase, but the swallowing process will be delayed. If the patient has a brainstem, then there will be a severe dysphagia and increased risk of aspiration. This is a simple algorithm but I would say that this not classically followed at every setup. It based on in which center you are working. Any patient with early dysphagia, like mostly stroke or any kind of brain injury patients, first clinical assessment, a neurological assessment starting from your cranial nerves. You all know oral examination, swallowing reflex, whatever bedside test is possible, and then you can go for the fees if you have suspicious of aspiration or patient is on rise tube. Then we assess, uh, first you have to see the various structure, and is there any structural abnormality, what is the vocal cord movement. Then you assess, give the food. So there are two study in the fees. First is a fiber optic laryngoscopy, where you are looking at the structures, anatomical structure, or starting from the oral, the oropharynx, the nasopharynx, and the larynx. At the same time, you assess the severity of dysphagia by giving some food. So what kind of food patients can tolerate. And based on the findings, you can give your recommendation what kind of food you are allowing, what consistency, whether the patient's required to be on rise tube or any other NPO, and you can modulate the different kind of dysphagia rehab. Now coming to the directly to the fees protocol. So it's like step-by-step procedure, what you would like to do. First is patient preparation. Like you have to keep the take a consent from the patient because it is quite invasive procedure. I would say it is more invasive than the barium modified barium swallow. So you have to inform the patient that we are going to introduce a scope or camera through your nostril. There will be a little bit discomfort, just but it will take just 5 to 10 minutes. Baseline assessment, like from the outside, you have to see if the patient has DNS, because we have seen a lot of times, because if there is a DNS, it is difficult to negotiate the nose. You can injure the mucosa, and mucosa is so thin, there will be definite bleeding. And at the same time, after introducing the scope, first you have to see what is the patient's secretion level. We have seen after just before doing the fees, just introducing the scope in the pharynx, you'll see a lot of secretion, and whether the patient can handle those secretions. Like if there is a pulling, sometimes the secretion itself aspirates. So if that aspiration occurs, probably you have to be very careful to try with the food. Then you have to check the sensory and motor assessment, like pharyngeal muscle strength, that is also called pharyngeal squeeze, laryngo arytenoid reflex, the cough reflex, and then swallow initiation. So you have to give the food and see what happens. So now you have to give the bolus based on the administration. So first, ideally, you should be thick, thin to thick, or very thin. You give thin, then modified thin, then you can go to solid. Then you have to see the observation. First is the whiteout phase. Then you have to see the airway protection assessment. So whether there is any penetration or aspiration of the food. Then post swallow assessment, like after the swallow, any kind of residual is present, either in the vallicula or in the piriform fossa. And repeat the with some modification. You can change the patient's head or posture. You can change the consistency of the food, and you ask the patient again to swallow, and again you interpret what is the problem. So based on that, you can decide on what kind of therapy or what kind of diet you want to give. Now, so first, we should try fees with different kind of food and different kind of like food and liquids. Ideally, water. What I do with the milk and little bit of milkshake. You can add some color, preferably light colored, white or green. Don't use any kind of red uh, coloring agent. Bolus consistency, first thin, thick, extremely thick. You can modify it. We thicken up, we usually make the changes, or we try actually with the puree food, soft food, semi-solid, and liquid. Volume usually start with a very small bolus, hardly 3 to 5 ml, and you can gradually increase the volume. And patient also has to be cooperative. Sometimes we take the patient with a stroke, or patient is on encephalopathy, little bit of restless or delirious. So for them, sometimes you need to restrain. So so ideally, the patient should be more alert, but in ICU or H2 patient, you won't get this kind of patients. And whenever you see the small aspiration, it doesn't mean that you have to stop the test. What you do, you change the consistency of the food. If the patient is aspirating with a very thin, you increase the thickness or keep different other consistency of food and see what's happening also. And you can do some compensatory maneuver, like change the posture, make the patient sit at 45 to 60 degree. Try to hold the neck or turn the neck on that side where there is a pulling. It can obliterate the piriform fossa. Uh, Now, when to defer the feeding, if you see there is a lot of secretion and there is secretion classically in the laryngeal vestibule, the patient probably at high aspiration risk. Now, contraindication of fees is again, it is very subjective. If the patient is on severe agitation and patient is not cooperative, but when you counsel the patients, I think patient understands. If there is a cardiac issues, but whenever we do fees, it's always like we check the patient's vitals. Patient is on monitor, you can see, because you are very close to larynx, so the vagus. So you're touching something, your scope touch, so vagus is stimulated. So there is a risk of bradycardia, there is a risk of syncope. So you look at the monitor, but we hardly encountered any kind of complications. Now, what I told you initially, like step-by-step process, that I'll describe few things. First is the velopharyngeal competency. So what is velopharyngeal competency? Like while swallowing, our soft palate, just try to visualize a soft palate push against the posterior pharynx or posterior pharyngeal wall. Okay. So it just close, it just doesn't allow the food to come up. So I'll just play the video here. We just entered the nasal cavity. This is the, you can see this is the turbinate. They are negotiating gradually. And here you could see in the posterior near the choana, this is the soft palate. Okay. So this is going up and down. This is the soft palate and it is closing the against the pharynx. So it is competent here. So first thing to assess is a velopharyngeal competency. Okay, this is now we have to go through the, yeah, so this is velopharyngeal competency. Next is we have to see the hypopharynx or larynx when it is at rest. You just keep the tip of the scope just at the above the just past below the soft palate, and you keep it at the level of base of tongue, and don't give any food. You just observe what is the happening. So what you could see here, so again for this patient, try to see the picture is little bit like here, this is the anterior. So the upper part of the picture is the anterior. So this is the base of tongue. This portion is a vallicula. So just above the epiglottis. And here, this is the posterior wall. So you could see the normal anatomy of the hypopharynx and the larynx. So I'll just trying to go down and see what is at the level of larynx. So you could see that cord is moving nicely and it is closing or abducting. It is closing the vestibule. So you could see this is also called the pharyngeal squeeze or the pharyngeal muscle contraction. Usually, patient is swallowing in the meantime. So baseline swallowing frequency is like 3 per minute. So very so. Sometimes, so here in this picture, we couldn't see that patient is swallowing. Otherwise, you could have seen the whiteout phase. Next is the pharyngeal squeeze. So here you have to ask the patient to make some sounds. So high pitch sound like E kind of sound. Again, you can ask the patient to make some loud sound like E in the loud form, like E, and yet see the vocal cord movements. So here, so this is nicely taken. So this is the epiglottis. This is anterior. You can see my cursor, no?
Yes, sir.
Yes.
Yes, sir.
So yes. So this is, what is this called? If this is epiglottis, then what it would be? If anybody answer? Here there will be tongue.
Vallecula.
Yeah. So this is vallicula. This is the epiglottis. So now ask the patient to make those sounds. You can see nicely the vocal cord is abducting and adducting with full force. So the pharyngeal muscle squeeze. And if this is moving nicely, so you can go ahead easily, at least with the pureed food. Even the patient doesn't have or decreased sensation at the pharynx or larynx, still patient can easily handle pureed food at this stage if you see the pharyngeal squeeze is present. Next is you have to see the secretion of saliva at the hypopharynx. So this is an important step. Like for this kind of, again, after introducing the scope, this kind of patient like stroke or we do a lot of patients fees of with Parkinson's, so they will have a lot of secretions. So how they are handling their saliva secretions, whether itself the saliva is aspirating or not, whether there is any penetration. So here you can see this patients see a lot of secretions around in the hypopharynx, and just try to focus here. My So here you could see, just a lot of aspirations. Itself, all this free, all the secretions here, yeah, it went inside. I think you would appreciate. So there's a lot of secretion and a little bit of secretion is going inside the vestibule. So this patient is already aspirating with his own saliva and there is excessive secretions. I'm trying to like there is a nice suction machine. It comes with automatic suction, the feeds, the FOL, the laryngoscope. So you can suction, but still this kind of secretion, it is difficult to go ahead with the fees procedure. Now, after suctioning, I try to go near the vocal cord. What you could see the vocal cord movement. Okay. Yeah. So cord movement is present. Yeah. So it is squeezing, but at least the airy epiglottic fold is so thick, you couldn't appreciate whether it is properly opposing or not. But difficultly in this, at this level, you could see that there is aspiration is happening. Okay. So secretion and aspiration. Next, coming to the larynx. Uh, so this is like, yeah. So focus on the larynx here. You didn't give any food. You see the vocal cord position at rest and at breathing and even in phonation. Ask the patient to talk and see what the vocal cord is moving and whether there is a cough reflex is present. You can ask the patient to count if the patient is alert. Ask the patient to count 1 to 10. Ask the patient to make high pitch or loud sound, what I say, through E. And you can see the patient's vocal cords full abduction and adduction. This video I already showed. So this is like full strength patient is saying E and full abduction, full adduction. So now laryngeal overview. One more thing we can see that is called pharyngeal stasis. So pharyngeal food stasis. So here you'd see I asked the patient, gave the patient already some food particle. This is called whiteout phase. We couldn't see anything. So this yellow food particle is coming. This same like liquid to little bit of thick. Here you can see this food particle is staying at the level of upper esophagus and in this piriform fossa. Even if the patient is trying to swallow, this patient again swallowed means this whole aryepiglottic arytenoid cartilage, it hit against the epiglottis, but still there is some food particle connecting. So this is called stasis. So sometimes if the patient tries to swallow twice or thrice, they can clear up. Any other cause of stasis of the food particle at piriformi fossa? Any guess? Will any PG will comment on what could be the causes of pharyngeal stasis? Or food particle stasis means the food particle is staying either in vallicula or in the piriform fossa. One most common is the upper esophageal sphincter is not opening. So that is the cricopharyngeus muscle. So again, there is a role of you can do like botulinum toxin in the cricopharyngeus. We could diagnose that this is a problem. Next is the coming to the location of food residue. Again, what I just now told, the food residue, if it is present at the level of vallicula, so just at the level of vallicula means the posterior base of the tongue and the epiglottis. Then you can see either if there is a probably weakness in the tongue base contraction or weakness of pharyngeal muscle contraction or weakness of the hyolaryngeal elevations. So hyolaryngeal elevations you can palpate from the outside. And if the food particle is accumulated in the lower part of pharynx, like piriform fossa, then probably the problem in the esophageal sphincter or the pharyngeal muscles. Next is penetration or aspiration that I already showed you in one video. So one thing is that, like, if there is an incomplete glottic closure, so vocal itself, the vocal cord is not opposing each other, or there is a reduced movement of larynx towards hyoid muscles, and patient has delayed swallow. So these patients are at risk of aspiration or penetration. So based on that, we can do some therapeutic maneuver, like you can change the food consistency. Ideally, food trial should be started with thin, at least very thin, and then gradually increase the consistency to moderately thick and maximally thick. And then you go to purid, and then after that you can go to semi-solid, then solid. Ideally, we ask the patient, if the patient is already eating orally, then we asked whatever food patient is eating at home, bring that little bit. We'll try with them. Of course, if the patient has signs of dysphagia clinically, and if the patient is on rice tube or brainstem stroke, we are suspecting swallowing, dysphagia or aspiration, we try with our like thin to thick. And of course, posture matters. Like if you chin tuck posture, we know lateral neck rotation. Those postures at that level, you can real time you can see whether this posture change of posture is helping to handle the food better. Now coming to like fees, of course, fees has some limitations. Like first, it's we cannot see what is happening in the oral phase of swallowing and what is happening at the upper esophageal at the level of cricopharyngeus. If the patient has esophageal dysphagia, classically we see in lot of Parkinson patients they will have esophageal dysphagia and brief period of whiteout. So when the entire picture is obliterated because all the pharyngeal muscles squeezed and they opposed against your scope. So these ways we cannot do here. There is a role of uh, modified barium swallow or video endoscopic swallowing assessment. But I would say that video endoscopic, these two are like complementary. Like if it's not necessarily like which is superior. You cannot say. Like fees is we can see the real time picture is less in. I'd say it's more invasive, but you can do at bedside easily, 5 to 10 minutes time. But and you can do it very sick patients. You cannot take one H2 patients or patient who is on rice tube, take him for the barium solo. That's sometimes difficult. If the patient is coming OPD basis, you are suspecting esophageal dysphagia, then probably you can go for VFSS or I'd say that fees is more easily doable. With that, I just conclude my talks. I expect some questions or any kind of confusions. I'll answer for that.
Yes, thank you, Dr. Gaurav, for nice video presentation, step by step of fees. I don't have much experience. It's my disclaimer regarding this. However, we can have few questions from the participants, whoever have experience on this. Uh, First of all, before taking questions, let us wait few minutes to get questions in the chat box. Just my, I mean, from one to suggestion from your side that
Yes.
what will you suggest for the training to the newcomers who wants to enter into learn this technique of peace? That what are the places where training can be done and how do they approach this procedure?
Okay. Training means, sir, during my postgraduate training at CMC Vellore, we had definitely exposure to fees. ENT surgeon, I still remember Dr. Kavin used to come to a rehab, the Rehab Institute, and we had a scope. So just to take a lot of our patients. Even yesterday, I was searching my phone. I found some videos done in 2000, almost 2018, during my second year probably fees. So, but again, the problem was that in between I was out of touch. Then later here I got some opportunity, I got some scope. It is just people are doing bronchoscopy fees, and and training was like you have to. There are a lot of people. I think there are 2 3 workshop also people are conducting, mostly in the south. In Kerala, I saw. I think their state conference. It's just doable or simple procedure. You can start doing on the mannequin first, and then slowly you can proceed.
There are different simulations methods also. Equipments are available.
Yes, yes, I think,
To,
sir.
yeah, to
But
work
the
on
problem,
this
like
endoscopy.
based on like complications, like yeah, first handling the scope,
Scope. Yeah,
like it's little different sometimes.
yeah, it's a
The
delicate
illumination is
area
up,
to put the
down,
scope into
and
it.
lot of times when I tried, like my picture also it went up like upside down. Ideally, the down part you should have your anterior. Like this is probably the ideal one.
Yeah.
Picture
So,
I'll just show you.
what is the absolute indication of fees that without this fees we cannot go ahead. We cannot tailor the swallowing protocol.
I think the brainstem stroke, mostly the pons or those kind of patients. Like we are still stuck with one patient, I think, by almost 3 months. Still, the patient is on rise tube. Patient is aspirating. Uh, so for those kind of patient, I think fees can give some help. And if you are one more condition, like in hospital, we cannot keep the patient for a long time. Like lot of patients first demand would be when the rise tube will be removed, we'll take him home.
Yeah.
So if you go manually, like slowly, clinically, you are evaluating every day, little bit of food, then probably it may be little delayed. Fees can just accelerate your, discharge process also. I feel like you can get rid of rise tube if a fees is showing no aspiration. You can allow more food orally. So we usually doubt on swallowing liquids or water. So I think swallowing water, that's the most difficult part. So when to allow water orally, based on to decide on that, we can do fees.
Okay, let's take a few questions from the chat box.
I
Basic
can
question.
read the questions. I
You
guess.
can. Yes, yes.
Yeah, yeah.
Please go.
So I'll start from the first. So Dr. Margaret is asking, so why food color is important? Why not red green? So I would say red. You can see the color. Can you see my screen?
Yes, we
Yeah.
can see your screen.
So red, if you put here, already it is a red. No, mucosa is pinkish or reddish. So that's why I cannot distinguish properly. But green definitely, yeah. So I used with the yellow food color agent. But yeah, yellow green you can use, not the red. Dr. Sharup Mondal is asking what's the usual dose of Botox in upper esophageal sphincter dissection. So far, I have not given my experience. Means I'm not experienced or I have not given, so I cannot answer on that. I'll move on to the next. Dr. Chandrakant is asking what else investigation can be added with fees to know about the oral phase swallowing. Chandrakant, oral phase, I feel that modified barium swallow or video endoscopy that barium swallow. How can we manage a chronic stroke patient 3-year duration with a rise tube and swallowing deficiency and bilateral vocal cord? Normal. I think, which one?
Yeah, I think no more questions are there in the chat box.
Yeah, how can we manage a chronic stroke patients with rise tube? Because we have to see what's the cause of like dysphagia for this kind of patients. What I told, starting from you see the oral phase, whether the patient has a
Can you
tongue
read out
movement
the
is.
question a bit louder because the audience must know
Okay, okay, sir.
what was the question.
Oh, sorry. Am I not audible?
No, the question must be very clear for the audience also.
Okay.
What you are going to answer for what
How
question?
can we manage chronic stroke patients, 3 years duration, with Riles tube and swallowing difficulty and bilateral vocal cord normal? This is the question from Dr. Soma Chandrasekharan. So, see what I told, 3 years duration. So you have to definitely see first evaluate what is happening, what's the cause, whether the oral phase there is a problem, or in the pharyngeal phase whether there is stasis. But the yeah, and at the last whether there is a problem in the cricopharyngeus, so that muscle upper esophageal sphincter is not relaxing. If you get any cause, then you have to treat as per that. So like swallowing rehab is would be the same one, like based on the answer. Like you can change the food consistency, you can change the maneuver, and if there is a problem, you can go for the Botox and of course the facial muscle exercise, and then pharyngeal stimulations. Now, so a lot of stimulator also has come. All those things you can try. So can I read the another questions?
Yes, yes. If you have questions, you can read.
What else investigation can be added with fees to know about the oral phase? That is the VFSS. What is the usual dose of Botox in upper esophageal sphincter? First, I have to read that. That's all, sir.
Okay. Thank you very much, Dr. Gaurav, for nice presentation. Actually, the purpose of this webinar is like that only because so many the institution they don't have facility of different type of procedures and investigations. This is
Dr.
the way
Pabitra,
by which we'll. Yeah.
Pab-
Hello,
sorry to intervene.
sir. Good evening, sir. Please go ahead.
Yeah, good evening. Hi, sir. It's very nice presentation. So there is one
Yes,
point.
sir.
I mean, the question that like, what are the prerequisite or what is the stage where we can initiate the phase evaluation? No? When to initiate this evaluation in
Sir,
a stroke patient?
sir, usually in stroke patient, what we follow if the patient is suppose based on that clinical evaluation first, clinical swallow
Uh-huh.
assessment. On day one, we assess clinically. If we feel that patient has at risk or of aspiration or patient is not able to swallow based on a nutrition, then we put rice tube and then 2 to 3 days of rice tube. Then it's still the patient is at risk with water. Usually they swallow. Talking about the sir basal ganglia stroke. That's the most common. So still the problem with the liquids or patient has cough, aspirating, we are in doubts. So I initiate the fees procedure, sir. And if the
No,
fees
some
is
patients who they are on the Ryle's tube as well as on the endotracheal tube, right?
yes,
Yeah. And you plan for, downsizing of the, the endotracheal tube, and at the same time, you also take out this feeding tube as well. Like so. So, what are the factors which you consider that it's a high time that we must evaluate on FESS?
yes,
Hello, am I audible?
yes,
Yes,
sir.
sir.
Yeah.
Sir, it's like when we suspect aspiration, that's one thing. Or when you want to like how long we'll keep the rice tube, that decision we take. And another one, if the patient is on tracheostomy tube and we are downsizing, that's again a role. Whether there is, because while doing the FOL, we could see any kind of larynx, any kind of laryngeal obstruction. So it helps us to early decannulation also. If the patient is on rice on tracheostomy.
Okay. Thank you.
And this scopes are sometimes I didn't show anything. Some patients you can easily go into the trachea, like through the vocal cord. Yeah, it's you have to go it very fast because while going inside trachea, there is a chance of like basically I'm saying that bronchoscope like thing. There is a chance of bradycardia. You can go and see a little bit of trachea, and if the patient on is on tracheostomy tube, you can sometimes put the scope through your stoma also, and you can see the larynx, means trachea, through the
Because why I
tracheostomy.
asked this question was no, like because GCS is also important, no, like that at what staging it can be initiated, right?
I think these
Sometimes
are
it
very
is a,
subjective, and center to center it varies.
yeah, true. Okay, thank you very much, Gaurav.
Yeah. Thank you,
Thank you,
sir.
sir. Thank you, sir. So, is there any questions for the in the chat box again?
Okay, I'll see, sir.
Yeah, one more question is there, most probably. According to the assessment fees, do we change the type of postural techniques?
The
Any
assessment fees,
protocol
do
for
you
doing
change that?
bedside saline challenge test? These are two questions started.
Yeah. So Dr. Amla is asking, according to the assessment in fees, do we change the type of postural techniques? Yes, yes. So if you, I'll just give one example. Like, first of all, patient has to be more alert while doing this posture change. Okay. So most of the time we see patients who are like still little bit of, restless, agitated. But if you see, get the patient is alert but on having dysphagia, then one thing, if you see, we see a lot of patients like food particle is not aspirating, but food particle is accumulating in the piriform fossa. So again, if it keeps on accumulating, then there is a risk that it can spill into the vestibule. So if it is accumulating more on one side, suppose right or left, suppose in the right side is more accumulating, what you can do, you can turn the neck on the right. So in hypothetically, we expect that this piriform fossa on the right side will be obliterated, and probably the food will not come and accumulate there. So this kind of posture technique you can try while while inserting the scope inside. But these are very thin lines. Like keep practicing and doing that. Hope I can answer this. Next question, like any protocol for doing bedside swallowing challenge test? There are a lot of bedside swallowing test. Like I think I heard almost. Uh, so bedside swallowing test definitely you do. What is bedside swallowing challenge? I couldn't understand, sir. Like we bedside also we try with same thing. Like you give water, give little bit of puree and semi-solid, and you see whether the patient is coughing, what is the elevation of the hyoid and the thyroid cartilage, and if there is a gargling sound, or very obvious, like after swallowing water, ask the patient to talk. You see is the change in the voice. If that is that they can clinically suspect aspirations. And one more test is to do, like if the patient is on tracheostomy, is to put some dye with water and give orally and see whether that dye is coming out through the tracheostomy tube, but their sensitivity is very poor.
So
Okay, sir.
we'll take the last question. We cannot extend it much beyond this. Treatment of swallowing difficulty only to liquids. Treatment for swallowing difficulty to the liquids.
Only again, we have to find out why the patient is not able to swallow liquids. Okay, there could be a lot of cause based on that. We have to decide on that. So today's talk mostly I saw that I thought that I'll describe like how will you go to fees and what structure you see, and mostly in my practice what we follow, like whether there is an aspiration is happening, that's very important. And second is like that if the patient is on tracheostomy tube, we try to see the vocal cord structure, because we don't want to take off or like decannulate a tracheostomy tube when there is already on-site paralysis, or if you are delaying, if the patient is not able to maintain or downsizing the tracheostomy tube, then definitely you can do a feeds. These are the two main. There are any other small things, like definitely the therapeutic part is very different. Like based on the fees findings, you can do a lot of therapeutic rehab. That may be discussed in some other days. I hope.
Okay, so we have to conclude the session. Thank
Okay,
you
sir.
very much, Dr. Gourav, for your nice presentation as well as answering all the queries. I hope all participants must have benefited from this presentation. It's a sensitization method that everybody must be aware of. Even we don't do also, we must aware about the things. That's the take-home message for everybody. Thank you very much, Dr. Gaurav, and thank
Yeah.
you, the IAPMR, for providing us the platform for conducting this monthly webinar. And I must thank my friends of my department and all our APMR members for helping us in organizing this webinar. Thank you very much. Thank you, everybody.
Yeah.
Right.
Thank you. Thank you so much. Thank you, everyone.